Welcome to the webinar, Hyperkalemia, Clinical and Cost Implications of Optimal Treatment, a systems-based focus on chronic management. This program is provided by the North American Center for Continuing Medical Education, LLC, and is supported by an educational grant from Rellipsa Incorporated. I'm Bill Cottarelli, Director of Pharmacy Revenue and Supply from Atrius Health in Watertown, Massachusetts. Also presenting with me is Dr. James Matera, Population Health Director at Centra State Medical Center in Freehold, New Jersey. This next slide shows our disclosures. The slide coming up now is our learning objectives. I will be speaking to the first and the last of them. I will talk to quantifying the clinical and economic burdens associated with suboptimal hyperkalemia treatment, and also talk about formulary placement and benefit design decisions, including some of the latest clinical cost data, treatment guidelines, and hyperkalemia treatment strategies. So let's begin. Hyperkalemia is a serious medical condition that can cause severe cardiac electrophysiology alterations, such as cardiac arrhythmias and sudden death. It's defined as serum potassium levels above the reference range, and patients with chronic kidney disease, especially advanced CKD, are at the highest risk for hyperkalemia, especially when other factors and comorbidities that interfere with renal potassium excretion are present. The prevalence of hyperkalemia in CKD patients is considerably higher than in the general population. A recent review reports hyperkalemia frequency as high as 40 to 50% in the CKD population compared to 2 to 3% in the general population. Hyperkalemia represents a considerable economic, societal, and health system burden. The financial burden of the condition is largely a result of the costs associated with emergency treatment at emergency rooms, inpatient stays, pharmacological treatments, and disease-related mortality. Additionally, there are considerable costs associated with adverse outcomes that occur as a result of suboptimal use of RAS inhibitor therapy, which may be due to discontinuation or down titration of the treatment based on concerns about hyperkalemia. In this study, published in the Journal of the American Health and Drug Benefits, the total costs for treating Medicare patients with CKD and hyperkalemia were 5 times higher than the total Medicare population. The mortality rate was more than 2 times higher than for that same population. In commercial patients, the PMPM costs were 15 times higher in patients with CKD and hyperkalemia than in the total population. Some of this is blamed on the lack of specific guidelines, but clearly hyperkalemia adds considerably to the cost and the complexity of treatments. This slide shows medications that can cause hyperkalemia. The use of angiotensin-converting enzyme inhibitors, or angiotensin receptor blockers, benefits patients with chronic heart failure. Adding spironolactone reduces morbidity and mortality in patients with severe heart failure. ACE inhibition also decreases cardiovascular mortality in high-risk patients, particularly in those with diabetes. However, patients who take a combination of ACE inhibitors and spironolactone are prone to hyperkalemia. Non-steroidal anti-inflammatory drugs decrease renin secretion, leading to decreased potassium secretion. The addition of NSAIDs to these patients can impair renal function to the degree of inducing life-threatening hyperkalemia. Thus, NSAIDs should be taken with caution in patients with diabetes or renal failure. Because of the relative decline in renal function with age, physicians should use caution when prescribing medications that alter potassium metabolism in older patients. Judicious monitoring of potassium levels is important in at-risk patients receiving those medications. This next slide specifically shows the effect of certain antihypertensive drugs on potassium retention. Clearly, ACE inhibitors show the highest risk. Use of ACE inhibitors are a risk factor for hyperkalemia and a significant concern, particularly because the indications of these agents in high-risk populations are very broad. In a 1998 study, 13% of patients at a Veterans Affairs General Medicine outpatient clinic had hyperkalemia. Risk factors included elevated blood urea nitrogen, serum creatinine, severe diabetes, heart failure, peripheral vascular disease, and the use of long-acting drugs. Hyperkalemia occurred in less than 6% of patients with normal renal function. As cardiovascular therapy has evolved, the growing population of patients with chronic heart failure has come to constitute a high-risk group. The factors promoting the development of hyperkalemia in these patients include underlying renal insufficiency due to poor cardiac output and reduced renal blood flow, as well as the high prevalence of diabetes in patients with heart failure. Initial studies examining the risk of hyperkalemia in patients with heart failure who were treated with aldosterone inhibitors revealed only a small, minor increase in hyperkalemia. However, later studies showed that as the treatment became more widespread, morbidity and mortality from hyperkalemia increased. Many individuals with hyperkalemia are asymptomatic. When present, the symptoms of hyperkalemia are nonspecific and predominantly related to muscular or cardiac function. The most common complaints are weakness and fatigue. Occasionally, a patient may complain of frank muscle paralysis or shortness of breath. Patients may also complain of palpitations or chest pain. There is reduced urinary acid secretion. Patients may report nausea and vomiting. The history is most valuable in identifying conditions that may predispose to hyperkalemia. Prior to the publication of the Randomized Aldactone Evaluation Study, or RAALS, the utilization of spironolactone was relatively small. In 1999, RAALS was the first of a series of trials to prospectively study aldosterone antagonist mortality benefits in heart failure patients. Patients with New York Health Class 3 or 4 ischemic or non-ischemic heart failure and ejection fractions less than 35% were randomized to spironolactone or placebo, with the majority of patients receiving a background of loop diuretics, ACE inhibitors, and digoxin. RAALS demonstrated a 30% reduction in all-cause mortality with spironolactone. Once published, this study was embraced by the prescribing community, and the use of spironolactone increased fivefold between 1999 and 2001. The unintended consequence of the increased use of spironolactone was that the incidence of hyperkalemia increased proportionately. This was not totally expected, as the RAALS study did not indicate a significant increase in hyperkalemia. The authors of this study speculated that there are at least 6 reasons why hyperkalemia is a more common occurrence in clinical practice than in the carefully controlled setting of RAALS. Physicians may not monitor potassium blood levels closely. They may neglect baseline attributes that predispose patients to hyperkalemia. They may prescribe inappropriately high doses of spironolactone or other medications. And some patients may purposely increase their dietary potassium intake, as is often recommended during treatment with diuretics such as furosemide. And finally, physicians may extend the RAALS findings to patients who, unlike other patients in the study, did not have left ventricular systolic dysfunction. Regardless of the cause, the number of patients with hyperkalemia increased dramatically. Many of these patients with hyperkalemia present at the emergency department. This study by Chang looked at hypertensive patients with potassium levels greater than 5 and those with levels greater than 5.5. In the majority of patients, the offending drug was either discontinued or the dose was decreased. A small number of patients were treated with diuretics to enhance elimination. While no specific guidelines exist, the aggressiveness of therapy for hyperkalemia is directly related to the rapidity with which the condition has developed, the absolute level of serum potassium, and the evidence of toxicity. At this point, I'll stop my presentation and turn the discussion over to my co-presenter, Dr. James J. Matera.
Thank you so much, Dr. Cardarelli, for that introduction. And I'm going to turn it over a little bit now to myself. I'm Dr. James Matera. I'm Medical Director of Population Health. And we're going to do a little bit on the clinical side of hyperkalemia, as well as identifying some of the costs and needs that we have. And I'll go through a few studies to show us how important this application really is for us. Whenever we look at a disease state or a symptom like hyperkalemia, we want to determine what the prevalence is. And we find that this is a very common situation that we see in clinical medicine. The definition of hyperkalemia would be a serum potassium level that we find greater than 5.0 milliequivalents per liter. And that puts an incidence in the United States somewhere between 2.5% and 3% in populations who have known risk factors. Of these risk factors, and we'll touch on a few of those, chronic kidney disease, or CKD, is the most common risk factor that leads to the finding of hyperkalemia. And this deals a lot with what we call the RAASI inhibitors, or the renin-angiotensin-aldosterone inhibitors, which a common side effect for them is hyperkalemia. But as we'll see, they are very important medications, so oftentimes this side effect limits our use of these medications. When we look at chronic kidney disease and we break it down into the 5 stages, and we look at this graph, I want to call your attention to the yellow bar, or stage 3 chronic kidney disease. That's probably the most common thing that you'll see in practice. And if you look at a Medicare and a commercial population, the prevalence of hyperkalemia is quite high in patients who have chronic kidney disease. Certainly the lower stages, it's a little bit less likely to occur, and as we go into stage 4 and 5, it is also very common, but focus on this stage 3. In the Medicare population, that's going to be about 13.3% of chronic kidney diseases in all stages that have a complication of hyperkalemia. When we translate that into what it costs for hyperkalemia, you can see on the slide here in both the commercial and the Medicare population, the per patient per month cost for developing hyperkalemia is again quite different. And if you look at stage 3, which I'll focus in the middle of the slide, it's about 2.5 times the per patient per month cost. And if you look over in the commercial, it's even larger than that. So you can take a cost savings by treating the hyperkalemia. And these are data that we get out of the Milliman analysis, which is very commonly used in hospitals to risk stratify patients. As far as hospital admissions, we do know that hyperkalemia incurs an increased cost in the hospital, especially in your CKD patients. And in these slides, we have the Medicare population on the top, the commercial on the bottom. Those with CKD and no hyperkalemia is on the left-hand side, and those with CKD and hyperkalemia are on the right side. And again, looking at the blue bars, which would be no admissions for these patients, you could see when they do not have hyperkalemia, they still have admissions, but the non-admission rate is much better. When you add hyperkalemia to both populations, you can see you dramatically increase their risk of hospitalization. And with this, of course, costs are incurred. And this could be for any different type of reason that they may get admitted, but it's going to increase our costs. This slide I'd like to call your attention to because this is a very interesting slide in that even though we're talking about the right side of the graph, which is hyperkalemia, we can see that there's actually a U-shape for the death occurring at various extremes of potassium levels. That tells us that potassium is a very intricately balanced electrolyte in our system. So if you're hypokalemic on the left side, your incidence of death is also very high. So you can see between about 3.2 and 5.0, the risk is very low, but then again, it starts to take off after that. And you can see on the bottom line with the triangles, ventricular fibrillation or cardiac arrest is not as impressive as death itself. So hyperkalemia is a very serious problem that we're facing. When we look at where hyperkalemia comes from, and this is a very busy slide, but it's either going to come from one of 3 mechanisms. The potassium is going to be redistributed, and it's primarily an intracellular cation, or there can be a problem with secretion of the potassium, which leads to a decrease, or it can be from increased intake, especially in things that you may not recognize like salt substitutes. When you look around that hyperkalemia are disease states that we all see very commonly, diabetes, chronic kidney disease, acute kidney injury or AKI, and cardiovascular disease. Across those, there are multiple bubbles which enhance where we get hyperkalemia from. And we'll focus on a little bit of those today. And what we're going to really look at is the excretion of potassium to try to help us. But you can see here it can go from many different things, and particularly medications. And on the far right side, on cardiovascular disease, some of those medicines we'll talk about today. We've seen a great increase, and I know Dr. Cardarelli is going to speak a little bit on the use of aldactone or spironolactone, and certainly we see that in our congestive heart failure patients now as well. So let's talk a little bit about heart failure. It's a very common disease state that you all see in your practices. And when we looked at a meta-analysis of the various CHF trials out there encompassing over 1 million patients, we also see that chronic congestive heart failure patients, especially those with systolic heart failure, have chronic kidney disease. And that occurs in about a third of the patients. This in and of itself leads to increased mortality rates, increased hospitalizations, and even increased readmissions. And this is thought to be because we're not utilizing our agents like the RAS inhibitors or not prescribing them to begin with, and many times that could be because we're afraid of or we encounter hyperkalemia. When we underdose these agents, we are leading to a twofold increase in 30-day mortality or readmission rates. Again, this speaks to the importance of these agents and also our important knowledge of where hyperkalemia comes from, and really puts an onus on us to try to prevent that outcome so we can maximize our dosing of these medications. So I'm going to go over two studies for CHF. These are a little bit older, but these are what led to the finding that the RAS inhibitors were very, very helpful in congestive heart failure. The HOPE study in 2000 used ramipril, an ACE inhibitor, versus placebo in over 9,000 patients, and they found that they reduced death by 16%, cardiovascular death in particular by 26%, myocardial infarction by 20%, and heart failure by 23%. This was the first study that really led to finding that these agents can increase outcomes in congestive heart failure patients. This was followed by the Europa trial in 2003, which really only looked at cardiovascular events, including myocardial infarction, and this used another ACE inhibitor named perindopril and studied over 12,000 patients. These patients did not have congestive heart failure, but it also showed that there was a reduction in myocardial infarction. When you look at the other trials that have come since that, they show very similar results in congestive heart failure and benefit to that, and that's what led to the development of the use of these agents, in particular in controlling congestive heart failure. This leads to an important dilemma in medicine. What do we do here? We know we have agents that reduce mortality, increase outcomes, so we don't go ahead and prescribe those agents and allow the hyperkalemia and deal with it, or do we avoid or discontinue these medications that are known to improve the status of a patient? When this happens, this leads to suboptimal outcomes because we're not maximizing our medicines, sometimes we're stopping them, or we're not adjusting them according to the patient's needs. In this slide, which comes from the KDIGO, or Kidney Disease Global Outcomes data, this was guideline 11, and it's very important for me as a nephrologist to look at this. I utilize ACE inhibitors and angiotensin receptor blockers in my chronic kidney disease patients, and in fact, our guidelines tell us that we should be using the highest tolerated doses of these medications. It also said, and these were guidelines dated 2012, that if we do develop hyperkalemia, we need to decrease or discontinue these medicines. If you look to your left on the graph, that leads to us using an optimal dose of RAS inhibitors in only 25% of our patients. 75% of our patients are either untreated or at a suboptimal dose. Again, this portends for much worse outcomes for these patients. So we have to come up with some type of solution. So let's focus a little bit on how we treat hyperkalemia. Basically, we divide this into three goals. The first two goals on the left side of the arrow are more for an acute event, whereas I'm going to focus a little bit more on the elimination of potassium. When someone comes into our emergency room and has significant hyperkalemia, we use calcium gluconate to stabilize their membranes, a temporizing measure. We then give them medications, including sometimes inhaled beta blockers or insulin, to redistribute the potassium to get it away from the myocardium, again, a temporizing measure, but the focus must be on eliminating that. And to that end, we have sodium bicarbonate, which can be used to alkalinize the patient, alkalinize the urine, and excrete some potassium. We certainly use loop diuretics, which we know cause some loss of potassium in the urine. And classically, we've used sodium polystyrene, and I'm going to talk about that in a moment. But now we also have some newer agents, which I think are going to change a lot of what we're dealing with in this arena in order to allow us to maximize our therapies. Prior to now, we've been using sodium polystyrene, and this was approved way back in 1958 before we really had any design-controlled clinical trials. And I would venture to say that it would be very likely that this agent would have a very difficult time being approved today with our current requirements and review process for medications. This was kind of grandfathered in. And in fact, when we look at the data through the years, there is really no convincing evidence that sodium polystyrene increases the loss of potassium in the feces, either in experimental animals or humans, and there's really no evidence that adding sorbitol, which is a common vehicle for this, to that binding resin increases its effectiveness. And there's actually concern that sodium polystyrene may not be effective unless you use sorbitol. Sorbitol is a very osmotic agent, which will draw some water out into the colon as well, and that's sometimes what leads to the fecal loss of potassium. But again, no real controlled trials to show us that this has been beneficial. In fact, there's been some evidence that it's detrimental. The FDA actually came out with a warning against sodium polystyrene in 2009, citing cases of intestinal necrosis, sometimes fatal, and other serious gastrointestinal events, including bleeding, colitis, or perforation, has been reported. The majority of these cases, it was attributed to the sorbitol component of the sodium polystyrene. There are certainly some risk factors for these patients who would get these adverse events. And those are patients who have prematurity, history of intestinal diseases or prior surgery, hypovolemic patients, renal insufficiency, and renal failure patients. Yet think about it, that's the patients that we're probably using this agent in the most. The concomitant administration of sorbitol with this agent was not recommended at that time. So we really have an agent that's not very useful, has no significant evidence-based data, but yet we continue to use it because it was the only player on the block. Now we have some newer agents that we can use when we're looking to treat hyperkalemia. And this is very important because a need certainly exists to control the hyperkalemia for several reasons. Number one, as we've alluded to already, it will allow us to use our agents, particularly our RAS inhibitors, ACE inhibitors, and receptor blockers, when we have disease states like congestive heart failure and chronic kidney disease, because we know they have a benefit there. That's been proven. We have the studies for that. We need to be using these agents in those patients. We also know that the safe use of sodium polystyrene sulfonate is questionable and not really a good option. So this led to the development of some newer agents, and I'm going to speak about those as well. One is Patiromer, and the other is sodium zirconium cyclosilicate, or ZS9, which is not approved for use. These agents may allow us to use and ultimately maximize our RAS agents, and if you remember my pie chart a few slides back, we'll be able to take that 25% of our optimal dosing patients and do better for them in these disease states. So let's talk a little bit about the OPAL-HK study. This was a study published by Matt Weir and his colleagues in the New England Journal about 2 years ago. And again, it uses the premise that we spoke about, that RAS agents are excellent agents to use in clinical circumstances, including congestive heart failure, chronic kidney disease, diabetes, and hypertension. And I would venture to say that many of your patients don't just have one of these entities, there's often a combination of those. Hyperkalemia often leads us to adjust the medication down or stop the medicine completely altogether. So they designed the OPAL-HK study to evaluate the safety and efficiency of Patiromer in patients with chronic kidney disease, in particular, who were maintained on RAS agents. They took patients who were in stage 3 and 4 chronic kidney disease, and their range of potassium was actually from 5.1, minimal hyperkalemia, all the way up to 6.4, which many of us would consider more serious. They also had to be on the RAS agents for 28 or more consecutive days. They then divided this study into 2 groups. In the initial treatment group, where there were 243 patients, they divided them into mild and moderate. Mild was 5.1 to 5.5 milliequivalents per liter, and they received Patiromer at 4.2 grams BID. The moderate group, which was a little bit higher, 5.5 to 6.4, used the agent at 8.4 grams BID. That was the initial treatment phase. During the withdrawal phase, they then randomized the patients, 107 of them, and in order to get into that withdrawal group, their potassium had to be greater than 5.5 at baseline, and then between 3.8 and 5.0 at the end of phase 1. And they divided those into a placebo group for the next few weeks and the Patiromer group for the next few weeks. And here's what they found in the results. In phase 1, the patients had a fairly significant decline in their potassium when using 4.2 grams BID of 0.65 milliequivalents per liter. Those that were moderate had about a 2 times more, twice as much reduction, down to 1.23 milliequivalents per liter. And if you look at the overall, it was about a milliequivalent per liter decline in the patients using the agent. So then in phase 2, you remember, they then took them and put them either back on a placebo or continued them on Patiromer. And you can see that those in the placebo group, their potassium went up. So from the end of phase 1 to week 4 in phase 2, their potassium actually went up, where those in the Patiromer group stayed the same. There was no increase. And that was clinically significant. So they also looked at diuretics. I want to touch base on this slide for just a moment, because a lot of these patients with congestive heart failure have to use diuretics. And there was a thought that maybe the addition of diuretics, which can cause potassium loss, would augment hypokalemia in these patients. And you can see here on the orange line indicating diuretics versus not, there's no significant change at the end of week 4. So the diuretics did not enhance potassium loss to any great degree. So we did not see significant hypokalemia. So I want to talk about a little bit of the strengths and weaknesses of this study. This was a great patient population for us because over half the patients had diabetes. Their average GFR was stage 3B, or 35 milliliters per minute. Again, probably the most common stage of chronic kidney disease you see. There was a wide range of potassium levels, and this agent is approved currently by the FDA for use, so it's available for us. The weaknesses here are that in the initial phase, if you remember, there was no placebo or active control. Everybody got Patiromer. So our conclusions were very simply twofold. Patiromer definitely reduced potassium levels, but then more importantly maintained those lower potassium levels in the patients who had chronic kidney disease and were on RAAS inhibitor therapy. Very important. That gives us some strength to be able to continue to maximize these results. So what this agent is, it's a cross-linked synthetic polymer which actually exchanges calcium for potassium in the GI tract, particularly in the colon. And it has a lot of advantages if you look at it compared to sodium polystyrene. It's a calcium counterion. There's a low swelling ratio, meaning it does not enhance a large amount of water out into the colon. So you don't get a lot of the diarrhea that was associated with that, although it can be a side effect, and I'll show you that in a moment. And it binds a good amount of potassium. It binds 8.5 milliequivalents of potassium per gram of Patiromer. And there's also significantly less sorbitol. And again, remember that that was the agent that may be leading to some of the downsides of our other agents. As far as adverse effects, you can see there was constipation reported, as well as diarrhea, 7.6 on constipation, about 4.5% on diarrhea. And also you have to be very alert for hypomagnesemia. Again, with a calcium exchange ion, you may lose some magnesium, so that has to be followed as well. About 4.5% of the patients did develop some hypokalemia also, and that led to some dosing adjustments. Another agent called sodium zirconium cyclosilicate, or ZS9, is a crystalline lattice structure that attracts potassium into that lattice, and therefore it exchanges potassium for sodium and hydrogen counterions in the entire GI tract. This agent is not approved by the FDA, And the trial that we're going to look at here, which was published in JAMA, or the HARMONIZE trial, looked at a primary endpoint where you wanted to compare mean potassium levels between placebo and various treatment groups getting ZS9. This was done in outpatients who had hyperkalemia or 2 consecutive potassium levels greater than 5.1. And what you see here, it's a little bit of a busy slide. Call your attention to the circles on the top, the clear circles. That was placebo. And then the 3 doses of ZS9, 5 grams, 10 grams, and 15 grams. You could see that it did reduce the serum potassium in a level range to normal within about 48 hours. So they all led to some improvement again in potassium. But this agent, as we stated, is not yet available. It has a similar profile, perhaps a little bit less in the GI side effects, but as of this time, again, not available to us. But both of these agents really provide a new forefront for us to be able to maximize our dosing of RAS agents. So a couple of final thoughts that I want to do here. I want to just remind us that hyperkalemia has led to us limiting our use of optimal RAS therapy, especially in patients who have chronic kidney disease and particularly CHF, and it certainly adds cost while increasing morbidity and mortality. In this day and age of adhering to the triple aim of medicine, those go against what we're trying to do. So we want to keep our patients out of the hospital and reduce their costs, and you'll hear a little bit more about that with Dr. Cardarelli again in a moment. And this is usually due to the hyperkalemia itself that leads us to limit these agents. And even in my own practice, I've been guilty of doing this, where I have no other choice but to reduce the agents. Now, with the addition of agents like Patiromer and ZS9, I feel that we're going to be able to do much better for our patients and maximize these therapies. We certainly know that a widening gap has emerged between guideline recommended therapy for these agents and real-world experience. So we have to take care of that potassium level in order to make these drugs more effective and utilize them to their full potential. Patiromer has been shown to be well tolerated and effective for the treatment of hyperkalemia in CKD patients with hypertension, remember our OPAL-HK study, and other comorbidities on RAS alone or in conjunction with other potassium-lowering interventions, i.e. the diuretics that we spoke about. Many of our patients, it would be wonderful if we could have them on one medication, but we know that in the myriad of symptoms and signs that patients have with congestive heart failure and chronic kidney disease, polypharmacy is very common. ZS9 has also been shown to be effective in reducing potassium to normal within about 48 hours and to sustain those levels. And this may be an adjunct to our armamentarium in the future, but as of right now, it is awaiting any approval. I'm going to turn my presentation back to Cardarelli for some other thoughts from a pharmacist's approach, as well as other cost containment therapy, and we'll be happy to answer questions at the end of the presentation. Thank you.
Thank you, Dr. Matera. Pharmacists can play a vital role in the management of hyperkalemia. They should be aware of newly approved treatment options and can assist with dosing the various medications used, as well as assess for drug-inducing hyperkalemia agents. An important part of this is educating patients about foods and medications that elevate serum potassium levels. Dietitians can also help with meal planning options for those patients. There are several challenges for the company's P&T committee with regard to these drugs. First of all, to identify and distribute evidence-based treatment guidelines. Secondly, to evolve the drug benefit design to provide access for these medications. Third, to provide the utilization data essential to providing continuing care to members. Fourth, to encourage a chronic care treatment approach so that those patients are treated on a continuing basis. And finally, to identify and reward those best practices that determine the best possible outcomes. As I've said before, for the past 50 years or so, managed care organizations have faced several challenges in designing and implementing medication coverage policies for its members. Originally thought of as a way to control ever-rising drug costs, the business has seen an evolution of its business model to encompass many different strategies, such as HMO, preferred provider organizations, point-of-service plans, and just plain old fee-for-service plans. Depending upon plan type, there will be different benefit language, coverage issues, as well as cost burdens and methods of controlling them. I'll touch briefly on a number of these. There are multiple areas within the treatment of hyperkalemia where managed care companies face significant challenges. Understanding the latest consensus treatment guidelines, as well as the metrics from quality reporting organizations, can enable managed care companies to build effective and successful pay-for-performance programs. These programs should be designed to provide incentives for both patients and physicians. Overcoming the barriers that cost medical literacy and patient behavior present will need also to be addressed. Improving patients' medication adherence and empowering patients to take control of their own care is of paramount importance, and providing physicians and treatment teams with current and accurate patient-level data will allow clinicians to better track their patients' progress, address treatment compliance, and better educate patients about self-management. Managed care employs a number of utilization controls in order to provide access to the most cost-effective medications. In these cases, you may see the use of prior authorizations, including some for some of the newer medications that include molecular testing requirements. They may use something like step therapy, where there's a preferred product that must be tried first before going to an alternate. Certainly the concept of formulary designs with open versus closed formularies, open formularies where all medications are covered, it's just a matter of what tier they're put in, whereas in closed formularies, certain medications may be actually excluded. And finally, the P&T review process itself still looks at the efficacy, the safety, and the cost of these medications. P&T committees do have a fiduciary responsibility to the organizations that they work for. One approach to maximizing drug therapy is the use of MTM services. There's no question that the value of medication therapy management programs, the value of these services can be measured in a number of ways. First, the patient benefits from improved outcomes. The patient also benefits directly from the individualized attention to medications and the roles that they play in his or her daily life. Third, physicians and other team members benefits when pharmacists apply their pharmacotherapeutic expertise in a collaborative process to help manage complex drug therapies. In general, health plans, employers, and payers benefit tremendously when they pay only for the medications that are safe, appropriate, and effective for the patient and his or her medical problem and are used as intended. Keeping patients out of the hospital is one of the most important and cost-effective goals of MTM therapy. The use of pharmacoeconomic evaluations is certainly controversial. There are issues with credibility, of the bias of the reports, as well as whether or not this actually represents science or is just another form of marketing. Resources are scarce, and the time to validate and attempt to replicate findings in an organization's population are lengthy. Critics have often stated that the economic evaluations of new drugs have rarely been used to inform healthcare decisions, despite the large volume of published studies. In this paper here, a new categorization for economic evaluations of new drugs is proposed, incidence-based and prevalence-based. The categorization is designed to increase the likelihood that decision makers are given more complete and usable economic information about new treatments. Results incidence-based evaluations, such as cost-effective analysis, focus on the impact of a new treatment on a health condition from onset until cure or death. Prevalence-based evaluations focus on the impact of a new treatment on a health condition during a one-year time period. Managed care companies try to project costs across their entire member population for the current and future fiscal year. There may be some value in using these tools to make those calculations. Managed care companies like to use comparative effectiveness research as a tool to inform healthcare decisions by providing evidence on the effectiveness, benefits, and harms of different treatment options. There are two ways that this evidence is found. The first is pragmatic trials where researchers look at all the available evidence about the benefits and harms of each choice for different groups of people from existing clinical trials, or they look at trials that generate new evidence of effectiveness or comparative effectiveness of a test, treatment, procedure, or healthcare service. Comparative effectiveness research requires the development, expansion, and use of a variety of data sources and methods to conduct timely and relevant research and disseminate the results in a form that is quickly usable by clinicians, patients, policymakers, and health plans. The goal here is to identify new and emerging clinical interventions, identify gaps between existing research and the needs of clinical practice to promote and generate new scientific evidence and analytic tools. Currently, CER is underutilized because of its limitations. Under the guidance of the U.S. Food and Drug Administration, most clinical trials are designed using a placebo-controlled strategy. The study design fails to compare a new drug product to existing products. You would always expect a new drug product to be superior to placebo, but that's not how treatment decisions are made in real life. The use of placebo comparators may inhibit the discovery of important information necessary for formulary decisions. CER could be conducted prior to product introduction to understand potential gaps in therapy and determine whether a new agent may make an unmet need. For formulary decision makers, the challenge remains how to incorporate CER into their day-to-day practice of offering an affordable, balanced drug formulary to their health plan members. This next slide shows the AWP cost of these agents. The ZS9, which is the newest agent, is currently undergoing FDA review, and therefore cost information is not available. Patiromer AWP is about $26 and change per packet regardless of its strength, and sodium polystyrene sulfonate is available from multiple sources. The average AWP per 15-gram dose is $5.79. So let's say you have a newly approved product and you want my company to provide access to it for my members. I'm going to want to know if your product is superior to existing medications for the same indication. Will the use of your product allow me to reduce expenses in resource utilization, such as emergency room visits, practice visits, labs, or imaging? How much will it cost me to provide access for your product? Will your product work for all populations, or are there distinct populations where it's less effective, be that age-related or ethnicity-related? In some instances, the discussion has moved beyond the consideration of efficacy, safety, and tolerability, plus cost, to include patient-reported outcomes. Many organizations employ an algorithm similar to what I have supplied here. In consideration of any new product, it first asks if the product being considered offers a substantial improvement over currently available therapies or is a new molecular entity with a completely different mechanism of action with potential to change the current standard of care. Is there a reason why this product should be used ahead or instead of the current approved treatment? Are there any safety or tolerability issues? And finally, can the organization afford to provide access to this medication? This ultimately answers the questions about coverage and any restrictions that may be placed on this product. There is little doubt in my mind that the role of pharmacy will become even more prominent in healthcare delivery as healthcare reform unfolds. Pharmacists will be tapped for their cognitive expertise and become integral members of the patient care team. With greater accountability for patient outcomes, providers will increasingly rely on pharmacy for patient-specific medication adherence information, particularly for chronic and complex conditions, identifying and managing gaps in care, and providing medication reconciliation at care transitions. Successful ACO models demand more integration of data, incentives, care plans, and healthcare services. Integration of medical and pharmacy data will be essential. The discipline and effectiveness of drug pricing strategies on the pharmacy benefits side of the business will continue to migrate to the less disciplined management strategies under the medical benefits. Aggressive management of the drug benefit and of the pharmacy network will be seen as critical to the ability of MCOs to provide affordable access to drugs. I anticipate that health plans will begin to apply the pharmacy benefit strategies on those drugs managed on the medical benefit. This will include aggressive formulary management, rebate optimization for branded drugs, a continued push towards generics, step therapies being implemented, mandatory participation of members in specialty drug programs for those drugs that require special handling or are particularly expensive. Efficient execution of value-added programs, such as medication adherence programs, should result in overall cost reduction. But this depends heavily on integrating pharmacy and medical claims and data capture systems. These integrated systems are prerequisites to new types of contracts that will include outcome guarantees and mechanisms to attribute values to different stakeholders for specific activities and/or outcomes. Healthcare stakeholders must remain vigilant about managing costs with all of the tools in the arsenal. The role of pharmacy is evolving and increasing in importance. There is an emerging market imperative to integrate pharmacy and medical services to optimize not only patient outcomes, but the economic return on investment. So in conclusion, managed care organizations can contribute to improved outcomes and reduced costs by increasing the understanding of current therapies, recognizing the potential benefit of future therapies, and developing an understanding of hyperkalemia and other therapy options. So that concludes my presentation. Thank you very much for your attention. We'll now open up the question and answer session. Good afternoon, and thank you for joining us for today's webinar. My name is Bill Cottarelli, and I will be your moderator for today's question and answer session. Joining me today is my co-presenter, Dr. James Matera. As a reminder, if you'd like to ask us a question, please type your question into the question box. Dr. Matera, do you have any opening comments for our audience today?
Thank you, Dr. Cottarelli. I'd like to welcome everybody to the webinar. I hope you enjoyed it. I hope you got some good information out of it. I think it's a very good topic in this day and age, and especially when we're looking at costs of medicines and costs of care and being able to maximize some of the things that we know our patients do better with. I think that helps a lot. So happy to be here and answer any questions that the audience may have.
Thank you, Dr. Matera. And as a reminder, if you do have a question and would like to ask us anything concerning today's program, please type it into the question box that's on your screen. Our first question today comes from our planning committee. And the question is, in the acute setting, where do you see these newer agents fitting into the algorithm of treatment compared with other options such as insulin? Dr. Matera, would you like to comment on this question?
Sure. Whenever I'm faced in the emergency room with a hyperkalemic patient, the first thing I try to determine is what is the acuity of the situation. These agents so far, Patiromer and ZS9, don't have an acute indication because the onset of action, even though it's lower for ZS9, can be up to 6-7 hours for that. So they don't really have a role right now in the acute treatment. In the future, I think we may see that. But when you're faced with a true acute situation where you have to lower or move the potassium quickly, and we didn't have a chance to talk about this in our webinar today, but what you want to do is use agents like insulin, dextrose, and bicarbonate to shift the potassium away primarily from the cardiovascular system. But that really doesn't move it. It just moves it. That really doesn't eliminate it. It just moves it from place to place. And then you have to try to eliminate it either through furosemide, or sometimes we even do dialysis on these patients when it's significant. So right now, the acute treatment is based primarily on how serious I think it is. Now, if someone comes in with mild to moderate hyperkalemia, somewhere in the 5-6 to 5.9 range, somewhere around there, and they don't have a lot of EKG changes or significant findings, then we may find a role for these agents later. But right now they should be kept more for the chronic, and we showed some good data showing that there are prolonged hypokalemic effects, including, with the use of diuretics. So in the future, that may become more of a role. Right now, they're not to be used for acute lowering.
Thank you, Dr. Matera. And I certainly agree. I think the urgency with which treatment is applied is directly related to that patient's individual situation. I think as the potassium levels rise and certainly as other symptoms present themselves, if there's an EKG that is abnormal or showing the tracing pattern, the typical tracing pattern of someone with hyperkalemia, that puts it into a completely different level of concern where it requires more immediate therapy. The Patiromer product, is very good for chronic therapy. Its onset of action is a little bit longer, might not easily lend itself to an emergency department use, yes, at least for those people who need more immediate care. One of the attributes of ZS9 is that its onset of action, according to the studies, is about 1 hour. So somewhere down the line, if that product eventually gets approved, maybe there's a place for it, maybe there's a place for both. It's really more a matter of, what our experience tells us once these products are available, and, the particular situation that patient is in at that point in time, as to whether or not treatment is urgently needed or whether it's just a matter of monitoring that patient, making sure that they don't get into any distress, and then slowly reducing the potassium levels back into the normal state.
Absolutely agree. And also, one other point is if we're successful in keeping our patients, especially those who are on RAS inhibitors, from developing hyperkalemia, we may not be faced with such acuity in the emergency room as a long-term process. Oftentimes I'll see patients, they come in, especially the cardiac patients, where they're on spironolactone, they're on an ACE, they're on an ARB, and those are the ones who come in with hyperkalemia that we have to deal with. Perhaps we can eliminate some of that by the use of these agents chronically.
That's true. And I think that, looking at this, it raises an important point because, as we said earlier, as you said in your presentation, only about 25% of these patients are optimally treated for their base condition. And the first pass at someone with hyperkalemia is to basically lower those medications that are used to treat, if it's a CKD patient, you're lowering the RAS inhibitors, so you're actually removing more patients from the optimum treatment level. So our ability to control hyperkalemia or prevent hypokalemia is critically important for treating other diseases. So the downstream effect of better control is better care all around.
Couldn't agree more.
Our next question comes from our audience. Thank you very much for this. And the question is, what patient concerns to pay attention to in retail pharmacy scenario and how to communicate to physicians effectively? So I'll start from a pharmacist perspective. And I think that, in any interaction with a patient, whether it's at the retail pharmacy counter in a clinic setting, whether it's a MTM situation, it's always important for that pharmacist to assess the state of the patient, how they feel about their medications, whether or not they've been taking them properly, whether or not they have any side effects or symptoms, or whether they're just having, difficulties. In the case of a product like Patiromer, it's pretty straightforward how you take it. It's a tasteless liquid. It doesn't have a lot of viscosity to it. It's not like some other liquids that have to be reformulated, and I'm thinking specifically about cholestyramine resins and things like that, where there's a texture and a taste to it. And certainly for any members of our audience who have ever tasted cholestyramine resin, you certainly will agree with the fact that I think it tastes pretty nasty. That's not the situation here. But you do have to pay attention to those signs and symptoms of hyperkalemia, the muscle weakness, the other subtle signs. You have to see how the patient describes their feeling. Certainly anything that rises above symptomatically the level that you can effectively communicate with the patient needs to be passed on to the physician. In retail situations, that might involve a call to the practice and just giving the physician an update. In a clinic setting, maybe it's a note through the electronic medical record or some other way of communicating internally. From a physician perspective, Dr. Matera, what type of information would you like to see coming back from a pharmacy?
That's a very good question. We see a lot of issues regarding the patient's ability to get the medication. That's one of the issues. And we actually, early on, after the acceptance of Patiromer, is we had one of our office staff specifically trained in how to deal with the form. We have a form that we use to try to get it approved. And she does a lot of the interaction between the pharmacy and the retail setting to get that. What I like to hear, and I try to always follow up on my patients with those medications to determine if they're tolerating it very well. But I also have the pharmacists who relate to us any issues that they may see, both in the ability to obtain the medication, and I must say we've done very well with a dedicated person who does that because she's been trained in how we need to handle those things. So once again, I think the key factor that you and I both have agreed upon is when you're looking at any of these situations, it's the collaboration of care among the specialties, and whether it be pharmacy, nursing, office physicians and patients, when you close that loop, the coordination of care is going to be much better. So I think that that's a big role for pharmacy here as well.
And clearly, in this particular situation, the pharmacist might see this patient a much larger number of times perhaps than you see them in your office or your office staff sees them. So there's an opportunity here to, capture a patient who's not doing well, a patient who's kind of headed in the wrong direction and doesn't quite know, is this important enough to call the office? How do I deal with this? This is a role that pharmacists can play, particularly in the retail setting, because they're very accessible. They have the opportunity to have that conversation with patients. Not to say that a retail pharmacy isn't busy. It is busy. But yes, there's an opportunity to do the right thing by the patient, to find different ways to communicate with different members of your staff or perhaps a nutritionist. And I think that, in your office, having somebody who deals with the paperwork issues, particularly things like PA forms and things like that, in your practice, you probably deal with a couple of dozen different insurance companies that probably each have their own unique forms. And there's certainly a need, and I've seen this done in Massachusetts, where they're trying to create a universal form that'll simplify that process, make everybody's life a lot easier, make it easier for you to get your medication to the patient, and also make it easier for that patient to not have to make multiple trips to a pharmacy before they get their medications. So I think that we're starting to head in the right direction.
Couldn't agree more. And actually, you brought up with cholestyramine. Do you remember the Coli bars that came out, the candy bars made of cholestyramine?
I do.
Talk about bad taste. I was a medical student when I tried one of those, and they were absolutely unpalatable.
Nasty. Absolutely nasty. And the cholestyramine resin itself, you can probably almost sympathize with patients who decided not to take that, even though it wasn't the right thing to do. So that was our last question for today. Any closing comments for our audience?
Once again, I think when we look at this, we look at what we're trying to achieve with our patients. And I think we showed some significant data that we are not utilizing medicines for particularly congestive heart failure and CKD patients, and sometimes it's limited by the adverse effects. We now have available to us a way to maximize our therapy, to hopefully push that needle out of the 25% that are optimally treated, and ultimately cut down readmissions and costs associated with two of the highest costs diseases, congestive heart failure and chronic kidney disease. And I think it's absolutely essential to start thinking in that way, even though many times we want to think, well, why would we give another drug to counteract an issue with a drug? But it goes down to what we want to do. And when we have the data that we have to show that RAS agents in particular and optimizing them are beneficial for our patients, this gives us another leg up in order to treat those patients. That's what I hope everybody comes away with today.
I totally agree. So I'd like to thank all of our attendees for staying with us for today's webinar. To be eligible for continuing education credit for today's activity, please log on to www.naccme.com, successfully complete the 10-question post-test and evaluation form, and immediately print your documentation of credit. This concludes today's session. Thank you again for joining us.
Thank you.